Again, good morning, good afternoon, good evening. I'm glad to have you join our webinar. Today, we're going to be looking at COVID-19. We're going to be looking at what's happened in the laboratory sector in the country of Uganda. And joining me this afternoon is Dr. Isaac Sewanyana. Isaac is the Director of Laboratory Service at the Uganda National Health Laboratory Services. We're very, very glad to have you. Isaac has his PhD in immunology and immunology of tropical and infectious diseases, and he runs the laboratory service out here. Isaac is very glad, we're very glad to have you. Just as I introduced you, I was just looking at your bio, and there is something that actually caught my attention. I note that in your lab, you're running over 1.2 million PCR tests. And PCR has come to be the big thing in the COVID era. Running 1.2 million COVID PCR tests a year is a very big volume. Would you just give me a little insight onto how what 1 week of your life looks like out at the Central Public Health Laboratories?
Yeah, thank you, Professor Kilian. Testing 1.5 million tests a year translates to testing equivalent to 5,000 tests a day. And that is not an ordinary volume. But we have built our industry-like lab throughput with automated platforms, especially the Abbott and the Roche and lately the Hologic, that allows us to have a very high throughput and the shortest turnaround time. So it's a system built on information systems, on high throughput platforms, and supported by a network of the sample referral system to get these samples quickly in the lab.
Great. Excellent. It's just really mind-boggling when we think about the numbers of tests that you have to manage. And we're glad to have you join us today to tell us how you've integrated all of this into COVID testing. But just before you come on, let me take a few minutes here to talk about the standard that governs laboratory testing. And I want to particularly look at some very important highlights here. Again, I'm looking at the ISO 15189, the 2012 edition, and I want to look at some guidelines around laboratory medicine as we go into this. But again, just so that we can appreciate the world in which we're living in today. And this is ISO news. Just over 700 participants from 144 countries actually did a huge webinar meeting just in lieu of their General Assembly meeting, just so that they could actually have discussions around what the International Organization for Standardization to be doing going forward. And I just had to throw in this quote from the president, Eddie Joroge, that clearly says he's confident that we will emerge from this crisis stronger and more resilient than ever. I think everybody who is in leadership has that impression, that as we go through COVID, and we will certainly emerge from COVID, certainly stronger and more resilient. And it is really important that as we think about stronger and more resilient, that we actually look at all the activities that are associated with what we do in laboratory medicine. Because again, just looking at the standard here, this is what ISO 5189 looks like. And it says this is the third edition, which replaces the second edition, which was the 2007 edition, which was changed for technical revision. But this international standard specifies requirements for quality and competence in medical laboratories. So there is the element of quality, and then there is the element of competence within the laboratory that this standard specifically looks at. And it goes on to talk about the fact that it is used in medical laboratories, and it is not just used in medical laboratories, but it is used for developing quality management systems and assessing their own competence. So within the system, what is the competence of the system to be able to repeat itself, provide reliable results every time? And a lot of the time now, people have come to think that the ISO 15189 in laboratory medicine is used specifically only for accreditation. But yeah, it is used by accrediting bodies, but also customers and regulatory authorities can use this standard to be able to ensure that the activities that are going on within the medical laboratories continue to be reliable. It's also important to note that this standard actually recognizes that almost 60 to 70% of healthcare decisions are based on diagnostic test results. And so when we're looking at the ISO 15189, it spends a huge part of its requirements look at what happens technically in terms of the activities that happen in a laboratory to ensure that this 60 to 70% of the healthcare decisions are actually made on very sound, reliable, and repeatable activities. And within the standard, it says conformance to this standard, that if you're able to conform to all the requirements, there are 25 major clauses in this standard, 15 on the management side, and another 10 on the technical side. And it says conformance to this international standard ensures that laboratories are going to meet their technical competence and also meet the management system requirements. And if you can do both and you meet both with the few non-conformities, then what you actually ensure is consistently delivering clinically valid results. And clinically valid results are really important to ensure that patient care is actually looked at. And this standard primarily is made and tailored to meet the needs of all patients. To meet the needs of all patients and the clinical personnel responsible for the care of those patients. So clearly there are two clients here. The first client, of course, is the patient, and the second client is the people who are going to use those results to administer any kind of healthcare aid to the patients. And it looks at, when you talk about the ISO 15189 and laboratory medicine, it's a very detailed and a very encompassing scope that it actually looks at. Because from the very second that the patient shows up to the doctor's office, he talks about examination request, what tests are going to be asked for, preparing the patient for collection of those of the sample, patient identification, ensuring that you have the right patient with you is very crucial in ensuring that you get the right results and you get the right treatment for the patient. Collection of the sample is key. What kind of sample are you going to be collecting? What are the collection tubes, or what are the collection devices that you will need? Transportation of that sample, storing the sample before test and or after test is very important, because the integrity of that sample is not only useful before the test, but the integrity of the sample is very important if you have to repeat a test. Processing and examination of clinical samples, subsequent interpretation. This is very crucial. Interpretation of results. And with the use of the standard ISO 15189, the third edition, which is the 2012 edition, when we talk about results, this is where you're actually taking a numeric value or a qualitative value that comes out of your equipment and translating it into something that is meaningful for the clinician to be able to use in treatment of the patient. And it talks about advice and then safety and ethics in the medical laboratory. Ethics is big, ethics is important, confidentialities, issues of confidentialities are still very important when we work in medical laboratory, whether you're talking about the results themselves, or you're talking about the patient who owns the results, or you're talking about the kind of care that the patient needs. In looking at this slide, these are two terminologies that I really want to address before I bring Isaac in to tell us some of the things that are going on here in Uganda. I want to look at the word validation and verification as they apply in our medical laboratories today. And because this is really very important, because we're talking about emergency use authorization test kits that are all over the place, in light of the fact that there is not enough information to be able to ascertain what test kits we can use. There is not enough information to ascertain what kind of treatment we can use. The element of validation and verification is key, that we understand what we're working with and how we're doing it. So the ISO 15189 talks about validation as confirmation through the provision of objective evidence that the requirements for a specific intended use. What is the intended use? The intended use in this case is to be able to identify the SARS-CoV-2 virus in the human body. That's its intended use. This is for the SARS-CoV-2 virus. And that application has been fulfilled. So in terms of new kits coming out, we have to use the validation process has to happen with them so that we can actually ensure that that intended use, when it goes into the market, it will be used for the SARS-CoV-2 virus. However, on the other hand, verification, which is basically the standard says confirmation through provision of objective evidence that specified requirements have been fulfilled. So when you do a validation of a SARS-CoV-2 kit, there is going to be specific requirements that this validation process is going to enumerate. If you're going to do a verification of that kit, you're going to be ensuring that what was enumerated during the validation process actually happens. So in the case of the SARS-CoV-2 test, you would have a quantitative answer if you're doing a rapid diagnostic test. Even if you're doing a PCR test, there's a cutoff value. So you would have a quantitative, qualitative answer that would be either positive or negative. But ensuring through a verification process that the intended use, the specific markers that were validated for are the specific markers that you get in a verification is key to ensuring that you're able to put this kit onto the market and you're able to use the products in the market for the purposes of the SARS-CoV-2 detection in treatment. So just looking at what happens around the laboratory and the guide from the International Organization for Standardization that helps govern issues in laboratory medicine, and specifically looking at the validation and verification, especially in this day and age. Let me now turn to Dr. Sewanyana, who is the Director of Laboratory Service at the Uganda Central Public Health Laboratory, and talk about what is going on within his facility and the kinds of things that have been happening. So Isaac, are you there?
Yes, please.
Isaac? Okay.
Yes, I am on.
Just to be able to get started, could you please just give us a background? Tell me something about what the preparation was in your laboratory as you prepared into going into managing this pandemic from a testing perspective.
Yeah, thank you, Professor Kilian. Apologies, my camera is not functioning, and I wasn't able to put comprehensive slides, but I'll be talking through these points. Uganda, like any other country, we were really caught off guard with the COVID, especially that we had a very limited capacity for PCR testing, capacity in the sense of the distribution across the country. And also because of the lack of knowledge about the SARS-CoV-2 as it unfolded in the early days. So we started the testing in Uganda, leveraging on the influenza surveillance lab. This was the most appropriate lab to do this kind of work in the beginning, when especially we had little knowledge about the transmissions and the risks that came with the virus. So we used the Ebola protocols in the beginning to ensure safety, but as we went to learn along, we had to tone down how we did it. So we realized that the demand for testing was very high, especially that before airports were closed and countries had shutdowns, we needed to look everywhere to make sure that we keep an eye on the epidemic. So we realized that one lab couldn't be able to cope with this. So we quickly developed a lab response manual. And when we did this, we brought together all the players in the lab, including the testing labs, but also the supporting partners. And when we did that, we were able to map out where do we have testing capacity for PCR, and what can we be able to allocate for COVID testing, and what are the gaps we have that we needed to fix to have this kind of labs up and testing at the earliest moment. And we also had to develop training materials. We had to train to develop safety training materials. We had to develop training materials for sample collection, sample packaging, and transportation, especially that with our response, we had instructed the population, sensitize the population to look out for COVID-like symptoms. And whenever they had these symptoms, they had to call the response lines, and then the response team would reach out to the population. So we needed to make sure that the teams that are doing this had proper training for safety and handling of specimen and specimen transportation. So we were able to put up a quick scale-up plan from the initial influenza lab that we were testing. And by the time, within 1 month, we're testing close to 2,000 test samples per day, which is really high volume for a lab to handle. So we had these labs that were ready to go, including the lab, my lab that has a capacity of doing up to 1.5 million PCR tests per year. And we had these labs to start testing, and we got them to test. And as we did this, we had a challenge of harmonizing and integration of information systems for the dispatch of results. And we were able to quickly leverage on the systems that we had to put up a results dispatch system, which is electronic. We're able to send text messages to individuals who have taken the test. And those who had emails could receive. But we had also built our results dispatch around the district teams. So the district health officer was in charge of the response across the district, and he had access to the electronic system, and he was supported with connectivity to ensure that they are able to print results, and they disseminate them through their network. We also had to deal with the logistics. So we had mapped out which labs are able to test and which kind of a technology they had. And we had to look out globally what is available on market to get these labs testing. So we had to activate those labs where we could easily get the supplies for the labs to test. And we kept daily updates of the supplies, because in the early days, the demand was bigger than the supplies we could easily get into the country. And so we had to keep daily updates and know where to divert volumes. And a number of times actually had to stock out in some labs, but luckily enough, we managed to always have supplies in another lab, and it got us going. So that's how we got to prepare for the testing in Uganda. Right now, we have scaled up testing to over 13 labs, mainly around Kampala, but we also had to set up labs in very high demand areas. In Uganda, we actually, when we had a lockdown and closed the airport, we let cargo flow on the roads. Being a landlocked country, so we had to let cargo flow, but cargo was flowing with truck drivers, and these truck drivers were acting as the Trojan horse for the coronavirus spread. So we had to put up labs at points of entry to be able to screen truck drivers that were transacting from other countries into Uganda. And actually by doing this, we greatly managed to reduce the transmission seeding into the Ugandan population, because at some point we're getting very high positive rates from these truck drivers, and we're able to isolate these truck drivers or deny them access into the country. And overall, it helped Uganda to keep down the transmission if you compared with the neighboring countries. So in that regard, we had to set up labs in a very quick and rapid way at the border points to be able to test. So we leveraged on the mobile lab concept that we had built around the East African region. And this very same mobile labs is what we used as the baseline to set up these mobile labs. But over the months, we have been able to strengthen the capacity of these labs. And we actually hope to maintain these labs beyond the COVID as surveillance labs.
Thank you very much, Isaac. You touched on some really important things there. I'm just thinking about those volumes. Initially, when we opened up and we spoke about your testing of well over 1.2 million samples for your EID, early infant diagnostic testing. Those were big numbers, but now with the advent of COVID, you're now doing 2,000 PCR tests. But I guess I don't want to say practice, but you had some time to be able to practice as you strengthened your lab. But it's also important to note that Uganda and the work that you do, you have the unique advantage that you've been able to, first of all, you had Ebola, and you've also been able to leverage on a lot of the things that you learned from the Ebola crisis, but also the development around HIV and the systems that were set up for HIV that you've been able to use. But I also like the whole methodology of building up on the influenza facilities and the influenza work. Again, this was SARS. This is part of the influenza family. So it was great that you guys were able to jump onto this and be able to develop the networks and use the district officers to be able to ensure that work goes on, and you are able to do as many tests as possible, but also most importantly, look at how to manage the immigration rates, because I know for most countries in Africa, the advent of the SARS-CoV-2 virus was really from an immigration point of view. So the work that you guys did with the mobile labs and doing the things that you did to support the points of entry, I think that was phenomenal work that was done out here. But as we go, this is March. We're talking about March 2020. We're now in October of 2020. Just tell me some of the things that you would have called a challenge and some of those learning points that you've had to deal with running the central lab and having to manage some of the activities across the country.
Yeah, thank you. Actually, we have not had a really challenging time like the times of COVID. Where the testing has dimensions ranging from public health response to travel to community safety, and also the economic dimensions that comes with it, where you have to close industries or factories or banks because workers are testing positive. So it's really been challenging. It has also been challenging because of the global demand for PCR. And as a result, it has been quite it's been very limiting accessing the kind of volumes of supplies you would want to have. And for that reason, we've even have some platforms that would have helped us a lot to this decentralized testing that we haven't able to use. Like, for example, the Gene Expert platform. The reagents are available by the company, but because of the global demand, they are not easily accessible in Uganda. And also, where reagents are accessible, there is also rationing. You cannot procure as much as you would have desired, because companies have got to ration to ensure that every country is able to access these reagents. So that's another challenge. The other challenge has been the quality of the reagents that directly impact on the quality of the results and the entire response to COVID. As you already know that COVID being a very new infection, all the reagents have just been, the available kits have not undergone a rigorous validation process. And therefore, it posed the challenge of knowing which are the appropriate reagents to use that are of high quality. We have also even seen a variation between the same manufacturer, variation in quality between lots. So this has also been a very big challenge. And it has also caused a huge dilemma when it comes to comparing platforms. You could have one lab testing positive and another lab testing negative for the same sample. And mainly because of the differences in limits of detection of the different platforms. And this has all been a huge issue, especially when it comes to sensitive populations like travelers, because a test is going to determine whether someone is going to proceed on his journey or not, or a truck driver is going to deliver cargo on time or not. And so those contestations coming from the differences in platforms has been a huge problem. We've also had issues of surging volumes, especially that we did not have to shut down the services that we offer for the routine services like HIV viral load and early infant diagnosis and the likes. And we had to use these very same resources to absorb the surging volumes for COVID. And that has been a very big challenge, and a big challenge it had on the quality and the quality management systems of the lab, because you had to quickly surge in a lot of human resource, your training as they're working, and you had to realign resources. So it has brought in a lot of compromise on the quality management systems of the labs, and also slowing down the labs in terms of the services that we're offering before the COVID. So, however, we've also had some solutions to some of these problems. Like, for example, the volumes were going out of hand, especially when everyone wanted to test. Some of the people wanted to test out of panic. And that resulted in huge volumes per day. And by having huge volumes per day, it slowed down the turnaround time. And that affected the timely delivery of results for especially positive patients where you needed to have an action. We had to overcome that by prioritizing the testing. So we moved away from testing travelers. Every traveler who is crossing a border had to be tested, regardless of their exposure or indication of risk. Then we had to move into populations. Whenever you had a positive in a community, then you test the entire community. Like, for example, if you had one person testing positive in an industry that has 300 workers. You would go in and test all the 300 workers. And this was not sustainable. So we have prioritized testing to specific categories, especially known contacts of cases who are symptomatic, patients who are presenting with COVID symptoms to health facilities. And then we also do targeted surveillance to keep visibility of what's happening in the community. Regarding the quality of reagents and the platforms that we're using, we had to be able to do in-country validations. And we selected one of the protocol, that's the Berlin protocol, to be our gold standard. And we had to validate every other kit against that. And that way, it also gave us an opportunity to understand how the different platforms compare. We are yet to perform another exercise where we compare the limits of detections of the different platforms, but at least overall, we can know how the different platforms can be able to compare with each other. We also had to institute an internal in-country quality assurance scheme, external quality assurance scheme. We actually call it interlaboratory comparison, whereby the testing labs are able to identify a number of samples, 5 to 10 samples, that they are able to share with sister testing labs, and these labs are able to compare the results. And if there are discrepancies, then the labs that are comparing are able to troubleshoot and find out where the discrepancies are coming from. And that has also allowed us to really have a good quality of results across the network of the testing labs. So overall, I think, yeah, that's the highlights of the challenges. And then also the transportation of samples. We have boosted our national sample transport system to allow every district, even without the testing capacity, to access the testing, and access to the electronic results system, and being able to reduce access to even people being able to use their mobile phone to access the results.
Yeah, Isaac, you know, just listening to you, I can really appreciate the volume of work and the logistics and methodology that goes into a lot of these things. And you actually mentioned the issue about limits of detection, which is a very, especially for the African continent, where we have a lot of platforms doing PCR. And I think one of the poignant points I like to go back is I like to go back to the Maputo Declaration and the Maputo Conference, which was a very important conference for this continent, the African continent, in terms of talking about what equipment we need to have on the continent and how we can actually help with standardization across the board. Because if we go back to the Maputo Declaration and we look at the things that were agreed to at the Maputo Declaration, one of the things that has been a big challenge on the continent has been certainly the issue around commodities, access to commodities. But if we had platforms that were open source and they were available, that would have actually put us in a different landscape completely with how we approach this. So I think COVID, unfortunately, has put us in that situation where we kind of sort of have to rewind the clock and see what the discussions were at the Maputo conference and the Maputo declarations and what they said. But again, those limits of detections are really important because as you strongly alluded to the issue of somebody testing positive and because they want to continue moving, they might use a platform that is less sensitive to get another result, which in this case, a negative result, to be able to allow them to continue moving. But unfortunately, what that just does for the community is it increases the number of potential suspects and contacts that need to be traced down the line. One of the things that I know that people are grappling a lot with in the US is the return to work, because you talk about how you have to test the whole industry if one person comes out positive. That has been a really big question. It's been a big concern to how do we go back to work today? If you have an industry or you have a company that has 700 staff, what do? Do you let them all come in? Do you bring in 30% of them? One of them turns positive out of 750 staff. You have to shut down. Everybody becomes a contact. And it sounds, when we're looking at it, we're just talking about numbers. But when you think about what the lockdown cost the African economy, $65 billion a month was lost to the lockdown during this period. So there are huge economic impact to the lockdown, the contact tracing, and the follow-up. When you put that against the testing, yes, it's true, we have to kind of sort of leverage who is going to be tested, when are we going to do testing, so that we can manage the commodities that exist. But today we have two interesting challenges. When you watch the news today, you hear that there is also there is a research in Europe, there is a research in the United States. I think over the weekend, I think that was Saturday, we saw the highest increase of new COVID testers. So that is going to put new pressure on commodities that are coming out here, because these commodities are made out there. When you get a new surge, it means that for countries in the African continent who are just beginning to build up numbers, for example, Uganda is just now getting to 9,000 positive cases. Still has a phenomenal death rate, which is still very low. But we need that's going to become a new challenge. And as we look at that challenge, my question for you now is, you're running the Central Public Health Lab, you're doing a phenomenal job, you're trying to balance your everyday testing, early infant diagnostic testing, vis-a-vis the SARS-CoV-2 testing. Now, what do you think, what is the way forward? How do you go forward? There's a new surge in Europe, there's a new surge in the United States. We are competing for the same commodities. You have to integrate this testing into your everyday testing, and we have to keep our population safe. What are the thoughts in Uganda? What are we looking at in Uganda in terms of testing and the way forward?
Yeah, thank you, Kilian. That's really a very pertinent question. And it's a question that's actually preoccupying us every other day. We cannot maintain the status quo with the way the pandemic is moving. The demand for testing is actually increasing globally, and that causes increasing pressure on the supply chain. And there's also a risk that some countries may actually go back into lockdowns, and that will also slow down the movement of cargo. So how we are looking into this in Uganda, we are actually trying to integrate our systems. We are trying to use innovations like, for example, heat extraction method, and that would reduce on the demand for reagents that are required for extraction of nucleic material. And this is one of the type of reagents that are actually very critically scarce. And it's, for a number of times we had to interrupt testing in some labs. It's been mainly not because of the primers or the other PCR reagents, but the sample extraction reagents. So we are looking at alternative methods of extracting, especially the heat method, as a way of cutting down costs. And we're trying to do in detailed validations that can allow us to confidently use this method with reliability. We are also have looked into batch testing, especially that in some of our populations, the incidence is still very low. So it still gives us a lot of room to do batch testing. We have validated this on a number of platforms that we're using it, especially the automated platforms. And it has been able to give us really good savings and good results. So pooled testing or batch testing is one other way we use. Probably to pooled testing means that you actually put several samples together. You can put 10 samples into one test tube and you test it as one sample. If it's test positive, then any one of the samples could be positive. So you go back and retest all the 10 samples to find out which one is positive. And if the tube is negative, then everyone in there is negative. So we have done this and we've optimized and we know up to how many samples you can batch per method without losing the sensitivity of the method. The other aspect we're looking into is the introduction of the antigen RDTs. We have extensively looked at RDTs, both antibody and antigen RDTs, whatever is coming out on the market, to generate country data that can allow us to inform how we can get to use these RDTs. Antibody RDTs have not given us very good results, especially when it comes to identification of acute infection. But we are having good leads on the antigen RDTs, 2 antigen RDTs, and we are in the early phase of rolling out these RDTs in a pilot mode and collecting additional data to optimize how best we can use it without losing view of the epidemic through getting a lot of false negatives. The limitation with the antigen RDT is the sensitivity, because unlike PCR where you are amplifying the nucleic material, so it allows you to detect very small quantities of the original material. With the antigen RDTs, you're detecting the protein load that is existent without an amplification, and that limits how the sensitivity of the platform. But we've come up with an algorithm that can allow us to use the RDTs without affecting the sensitivity, especially in populations like, for example, patients who are presenting with symptoms. RDTs symptoms normally tend to coincide with high viremia. And so those patients, we believe that the RDTs will be able to work well. And this is important because the hospitals are able to quickly isolate this kind of patient, and also the caregivers using the appropriate PPEs to avoid exposure of the health workers to occupational infections. We are also having a different...
yes, Isaac, you know, just listening to you, and last week we had the discussion on pool testing, and this is something that I'm particularly interested in because when we last week at one of our virtual hours, when we had this discussion around pool testing, it's a great thing in terms of cost saving and the amount of tests that we have to run out on the African continent. But the challenge we had, which is something that I bet you must have looked into, or you might have to look into, is we note that there are a number of transport media, and because we have people transporting in 5 ml, 2 mLs, some in actually 1 ml because they are using centrifuge tubes. So there is a number of different volumes of transport media. And as a result, there is the fear that because we're not using a standardized volume for our transport media, we might actually, in the case of low viremia, actually be diluting the possibility of a detection. So if you have the transport media in excess in volume, And then you have to now go in and do pool testing. You spoke about 9 to 10 samples per well. That also we actually would have done a double dilution, would have diluted in the wrong transport media volume. And then when we come now to the pool testing and we have multiple patients per well, there's a very strong chance that if this particular patient was just beginning to, the virus was just beginning to exhibit, they're still positive, but we might most probably lose them because their low viremial status and the number of dilutions might actually cause them to be negative, which means in actual sense, they would have gotten a true false negative result just due to the whole pooling effect and the poor collection methodology. So I guess that's something that you're looking into in terms of ensuring that the transport medium stays constant and consistent as we go into pool testing, because pool testing is certainly the way to go right now where we are. But again, we want to take it, I'm going to add with a grain of salt, because in the case of Uganda, I also noticed that our numbers are beginning to go up, which means that we're soon going to get to our critical volume, rate, where we might have to consider how many samples we want to pool per well to continue to be effective. Maybe you might have to drop from 10 down to 4. I'm not sure, but you are the one in the field who is doing this. But I'm also excited to talk about the antigen testing and the rollout. I think that's the antigen testing certainly is going to go straight into the virus detection. The antibody, I think we'd have to hold on an antibody for a much longer time. I think the best use of the antibody with where we are today and the testing methodology, we might want to hold on antibody testing, do this much later down, most probably the end of the year, early next year. And we might only be doing it just to see whether we've actually gained some level of herd immunity vis-a-vis the number of positives that we've had, and in terms of treatment cases and what is the management for treatment going forward. But I think these are some phenomenal things that you touch on, and I think these are really important things for us to be looking as we continue to manage this whole testing area. But Isaac, just before I let you go, sitting where you are today, tell me, what are you thinking? What are you looking at?
Yeah, that's a really very hard question. At least we know that COVID is not going to go away tomorrow. It's something that we're going to keep up with, and it's going to change a lot of our lifestyle, especially when it comes to travel. So I am looking at a plan to build capacity to do COVID testing very easily, very efficiently, and easily accessible. It's not only going to be COVID, but COVID has now made a respiratory infection of testing very critical. Yesterday, it was just enough to have a running nose and you declare you have a flu. But moving forward, it's going to be important to know what kind of respiratory infection you're carrying. And so it's going to change how we deal with respiratory infections, and it's going to increase a lot of demand for respiratory infection testing. And overall, COVID is teaching us that zoonotic outbreaks are real, and we must have very strong surveillance systems globally, networked, that can allow us to quickly detect this kind of infections and to avert them before they get to spread across the globe. So COVID is really changing how we're looking at everything.
Thank you, Isaac. I hope you have a few more seconds to spare while getting to the top of the hour. We might have some people in our audience today who would want to ask us a question. If you're listening to us wherever you are around the world, please just raise your hand and direct your question to either Dr. Sewanyana or myself, and we'll be able to give you an answer. Or if you have a comment you want to share with us at this time and your experiences anywhere in the world, that would be great. Anybody with a comment or question? I guess we did a fine job at trying to have a nice discussion about what is going on. Who is that? Laurent? Laurent, do you have a question for us? Just unmute. Laurent? I guess Laurent is having some problem. If you just type in your question in the chat box, we'll be very kind and we'll read it out for you. Anybody else with a comment or question for us? Okay, yes. I'm very ashamed I can't pronounce. I'm very ashamed I can't pronounce that name, but that's yeah, your hand is up. You're the only one with the hand up now, so just go on and speak. That's Laurent. Yeah, Laurent, please speak.
Yes. Professor Songwe.
Yes.
Thank you for the presentation. And Dr. Sewanyana. We are inquiring which tribes are allowed to do the COVID test using the antibody test currently in Kampala. Thank you.
Laurent, if your question is which test are we using, Dr. Isaac mentioned that they're still doing studies and they have some good prospects. So there is no antigen testing, no serological testing that is going on in Uganda right now that I think we know.
Oh.
Isaac, am I correct?
Yes, you are. We're only planning to do a pilot. We in targeted places to get additional field data on top of the validation data that we have.
Okay. So, Laurent, there is no serological testing that has been approved yet in the country of Uganda, but just keep tuned onto the Ministry of Health, or you could reach out to Isaac out of the Central Public Health Labs once a decision is made, and they will let you know what kits they are. I would not even dare to tell you which kits have gotten close to the validation prospects. That is still work in progress. So just stay tuned. Actually, this would be a good place to stay tuned to. Listen to us and you will find out. Okay?
Fine. Thank you very much, Professor.
Thank you. Any other hands? We are right at the top of the hour. Testing services is quite challenging, especially because of erratic supply of testing kits. Do you consider a critical step to test every suspect who presents with flu, cough, and fever? These symptoms / conditions have been there before. Isaac? Are we going to test everybody who comes up with a symptom?
Oh, sorry, I muted. Obviously, it's not possible to be testing everyone with symptoms, especially as the epidemic expands. We shall get to a point where we shall encourage people to self-isolate when they suspect themselves. But going forward in the future, it's not going to be business as usual. we won't be able to ignore any respiratory infection. We're going to have to continue doing testing for respiratory infections, for COVID, and for any other infections moving forward. And so countries must prepare to build this kind of capacity, especially if it's going to impact even how we travel in future. But as we get vaccines, I think also that will be another step forward.
Yes, the whole discussion around vaccines is a really big discussion, and there's so much work that is going into it. Isaac, once again, thank you so very much indeed for joining us this afternoon. Morning, wherever you are, and evening for some people where they may be at different points of the world. I think this has been a very useful discussion and great to look at the perspective from the Ugandan side of things and to see some of the tremendous work that you and the rest of your scientific colleagues are doing in Uganda. Great job, well done. And I look forward to having more of these discussions with you, and we continue to see what's going on. But before I end, Isaac, do you have a quick goodbye to say to our participants?
Yeah, thank you all for listening. And I wish you a good week. All of you stay safe and support Kick COVID out of Africa. Bye-bye.
That's a good one. We do really need to kick it out of here. Okay, so we never want to end one of these without continuing to tell you to stay safe. It's always a pleasure to have you. Please make sure you check your temperatures, ensure that you stay within the normal range. Wash your hands, running water and soap, 20 seconds at least. If you could do it for the whole morning, the whole afternoon, the whole evening, the better we all are. In the absence of water and soap, please sanitize. And again, please make sure you have some kind of face wear that protects any of the virus jumping out of you. This is a droplet virus. And with the face mask, we still want to continue to maintain our social distance. We want you to be 2 meters away from everybody else so that we all can manage to contain this. Again, thank you so very much indeed. Staying safe. You could reach us email